Dear postgraduate students, I am Partha, neurologist, National Professor of Neurology, India, presently working with the National Health Service in Liverpool, England. I've been asked to talk to you about ataxia, a clinical approach. This talk is intended for MD students who are sort of nearing their course. And that's me. I am a Kolkata Medical College graduate from 1990, and I've been doing my training and service in neurology over the last many years. I wish to dedicate this talk to our COVID warriors who have laid down their lives in the line of duty, and I pay my homage to the countless lives that were lost in this current COVID illness. In this talk, I have got no conflicts of interest or financial disclosures, full stop. I will be mentioning a few off-label drugs at the end. These are from the American Academy of Neurology. My talk overview, I'll be talking first about the history of cerebellum, then something on anatomy, clinical approach, followed by investigations. I'll be talking mainly about reversible and acquired conditions of cerebellar dysfunction. I feel the genetic causes, which I will be touching upon here, is better left to the DM neurology talk. And you can refer, if you're interested, to my masterclass, which I gave for the API recently, where it is a more detailed talk over 1.5 hours. Any questions you can address to me on the email given. Right, so the cerebellum nomenclature. Following the history of exploration of the human body, we have realized that the origins of the cerebellar exploration can be attributed to the great Greek scholar Galen early on in the 1st century AD. Before that, for 2 centuries before, there were some Greek scholars who were also exploring the cerebellum. The term is in Latin. It has been attributed to Leonardo da Vinci that he gave it the name, but it cannot be right. It has to be the Greeks who were dissecting oxes and other animals, because human dissection was not in vogue till Vesalius dissected the first human body. For the interested individuals, I'll refer you to the historical articles, which gives credence to the Arabic scholars, and you can have a full discussion about the nomenclature of the cerebellum there. Now, the cerebellum is an organ that has evolved with time. In the very beginning, we had the shark. Cerebellum, you can see, is very small. It consists of the flocculonodular lobe, which gives the eye movement and the ability to move the head of a small organism. Then comes the quadrupeds, the rabbit. Here you can see the cerebellum increasing in structure and becoming more robust to be able to control the activities of the limbs. And finally, this is the shape and size of the human cerebellum, which is quite big, because apart from locomotion and eye movements, it subserves several other functions. For the purpose of today, we'll be sticking to the ataxia, i.e. the locomotor functions and integration of the cerebellum. Now, we have the small cerebellum out here, the flocculonodular lobe, and the vermis out here. Then we have the anterior lobe, which is consisting of parts that control the movements of the appendages. And then we have the 2 large posterior lobes, which make up the lateral lobes, hemispheres of the cerebellum. And these have work to do with not only movement, but cognition, language, autonomic nervous system, initiation of movement, and many more other undiscovered functions till date. Let's talk about the 3 cerebellar peduncles, which connects the cerebellum to the midbrain, to the pons, and to the medulla oblongata. Now, of the 3 cerebellar peduncles, you must have to appreciate that there are afferent connections coming into the cerebellum and efferent connections that leave the cerebellum. Thereby, the cerebellum acts as the huge integrator of neuronal signals from all over the body and integrates them to deliver signals to the next part of the brain, which is the cerebellum, then via the midbrain onto the thalamus, and then onto the cerebral cortex. And you can see very nicely how there is a very well integrated connection between the dentate nucleus, which is deep inside. It's one of the nuclei, major nucleus outflow tracts of the cerebellum, connecting outwards through the superior cerebellar peduncle, and then leaving out here to decussate in the midbrain with the midbrain nuclei, and then going forward to the thalamus, and then finally thalamus to the cerebral cortex. It is advised that you know this diagram well to understand why the cerebellar dysfunction affects the same side of the body. This particular cartoon actually illustrates to you the feedback loops that exist within the cerebellum. And you can see out here, once again, what you saw before, the superior cerebellar peduncle communicating with the thalamus to the cerebrocerebellar cortex, and then again looping back via the pontine nuclei through the middle cerebellar peduncles, which is the incoming impulse into the cerebellum, to maintain a feedback loop. You have also got to consider the vestibulocerebellum, whereas the vestibular nuclei are there and they communicate with the interpositus nucleus. And there is also the medial vestigial nucleus, which to do with the balance and how they communicate, again, very robustly to give good control of the vestibular cerebellum. And of course, there's a spinocerebellar structures coming inside to report to the cerebellum and take signals away from there. This particular layer demonstrates the three layers of the cerebellum: the molecular layer, the Purkinje cell layer, and the granule cell layer. These are very well arborized circuits, which essentially maintain that the cerebellum has got very intense climbing fibers that bring in signals from the whole body into the cerebellum, where it integrates, and the dentate fibers through the deep cerebral nuclei, the dentate nucleus, reports back to the thalamus and to the cortex. The next diagram out here shows the various types of cells within the cerebellum: the Purkinje cells, the Golgi cells, the granule cells, the basket cells, and the stellate cells. And you can see the complex arborization that exists within the cerebellum. There's also the fibers coming in, the mossy fibers that you can see out here, and the climbing fibers that you can see out here, making dense arborizations, and then again, communications with the deep cerebellar neurons. I want to emphasize to you this particular diagram, which shows you how the mossy fibers and the granule cell dendrites form a glomerulus within the cerebellum. And you can see the large number of interneurons and connections that are in there that makes it all possible for the integration of signals coming afferently and efferent signals leaving the cerebellum for control. So what is ataxia? Coming to the clinical portion now. Taxis means order, taxonomy, ordering of animal species. Ataxia, when that order is disturbed. So we have where the movements no longer lack their normal fluidity, but it is broken up into small segments or components of individual movements. That's what happens when there is ataxia. So what controls it? Well, we need afferent signals coming in from the proprioceptive sensory apparatus. There's also the vestibular connections that bring in signals, and the cerebellar, as you have seen from the previous diagram, is the master integrator, a supercomputer, which controls a lot of the things that will enable the body to react to various different changes in the environment, from the labyrinthine, from the tactile, from the visual, we'll come to that later, and from the proprioceptive signals. So what happens when there is a loss of proprioception, and how does it happen? It can happen from problems in the nerve roots, from the nerves, from the dorsal root ganglia, from the spinal roots, and from the dorsal columns. So the person will be having a high steppage gait because the person doesn't know how high to lift the foot, because the proprioceptive signals are not coming efficiently from the joints, from the muscles. We have pseudoathetosis. When the person spreads the fingers out into the open, there is a constant riding movements of the fingers going on constantly, because the signals from the fingers do not reach the cerebellum and go back to the fingers efficiently. So there's a constant groping around that takes place. On examination, we are well aware that if you have a peripheral neuropathy or a ganglionopathy or a posterior column disorder, the distal reflexes are all lost. There is vibration sense and joint position sense loss. There's a tremendous amount of visual inputs that controls everything. When that's lost, the patient falls off. But there is no dysarthria, difficulty in speaking, or nystagmus, because these have to do with other systems which are not affected in sensory ataxia. We mustn't forget the small receptors in the skin that control all the afferent signals that go up through the nerve roots. So any disorder affecting these structures, the Pacinian corpuscles, the Meissner's corpuscles, the Merkel's disc, and the Ruffini's corpuscles, they all control the afferent processes. So if those are disturbed, we'll immediately have difficulty in proprioception as well. Moving on from there, I want to show you how the vestibules, our inner ears, the sacules, the utricles, the semicircular canals, have a large contribution in enabling the body to be aware of its position in space. And these vestibular nuclei, you can see, control the movements of the body by reporting via the vestibulocerebellar pathways and control the movement. So what happens when acute labyrinthitis or Meniere's disease, you get dizziness, vertigo? There are some features in nystagmus that help you distinguish between a central nystagmus and a peripheral nystagmus, where it is rotational and the fast faces away from the lesion. And there is, of course, resolution quickly due to central adaptation, and the person falls towards the side of the lesion. And of course, there is no limb ataxia or dysarthria with vestibular ataxia, with peripheral neuropathy signs being absent. Now, if you look at the eyes now, and this diagram shows you again the oculomotor control with the different three nuclei of the cranial nerves controlling eye movements, and how the medial longitudinal fasciculus acts as the connector between the parapontine reticular formations and the medial longitudinal fasciculus over to the right frontal eye field. So the cerebellum again acts as the coordinator of the signals that control the sustained pursuit eye movements and gaze holding, as well as the other vestibular ocular responses, whereas the saccades and the pursuit movement initiation is controlled by the oculomotor vermis. We talked about this in the development of the cerebellum. So what are the clinical signs of ataxia or cerebellar dysfunction? First of all, there is dysmetria. That is, there is past pointing and overshooting past the intended target. There is dysdentachokinesia, whereas when you ask the person to make rapid alternating movements, there is a difference or irregulation between the rate, range, force, and accuracy. There is dysarthria, and we have all seen alcoholic patients having dysarthria with an irregular pattern. There is hypotonia that is seen, oculomotor signs, nystagmus, and then gait ataxia. We see wide-based staggering gait, and the tremor. There is an intention tremor, but it can be a rubral tremor because of the circuit from the cerebellum going past the red nucleus in the midbrain being affected. So in clinics, how do we differentiate afferent ataxia from a genuine cerebellar ataxia? We've seen the role of the visual. If the person closes the eye, the ataxia is increased. There is some element of eye movements. There is dysarthria. Whereas if it's mainly an afferent ataxia, there'll be lots of sensory deficits and absent reflexes. Don't forget psychogenic ataxia to be distinguished. For MD students, I would really like to talk about the acquired ataxias more. There is a group of congenital ataxias, the ciliopathies, where we get the Joubert syndrome, the molar tooth sign, the Dandy-Walker syndrome that you see on the MRI, the Chiari malformation that you talk about in neurosurgery. There are degenerative ataxias, I'll be touching upon them, CJD, and there is a big group of geriatric ataxias. I will just touch upon them here, but mainly I want to focus on the vascular cerebellar syndromes, the neoplastic cerebellar syndromes, both in children as well as in adults, the infections of various different types, I'm sure you've seen them, the inflammatory autoimmune types of post-infectious cerebellitis, ADEM, Miller-Fisher, and the immune ataxias the celiac ataxias. We mustn't forget the paraneoplastic cerebellar presentations, the metabolic presentations from hypothyroidism, hypoxia, vitamin deficiencies, and a large number of drugs that can cause cerebellar ataxia and trauma. So moving on, this particular diagram gives you a list of the acquired causes of cerebellar dysfunction. I have been talking about them in the earlier slide. The genetic ataxias, just for laying them out on one slide, there is a pure cerebellar type. You can get cerebellum plus eye movement disorders with retinopathy, SCA7, SCA6, and some of them. There is, of course, a large amount of overlap. Some cerebellar disorders are accompanied by peripheral neuropathy, some others with movement disorders, including DRPLA, which you are aware of. There is the autosomal recessive, and the family history will tell you about the cerebellar ataxia type 1, again with oculomotor abnormality, with peripheral neuropathy, with other movement disorders. There is the X-linked cerebellar abnormalities with fragile X tremor ataxia syndrome, and mitochondrial cytopathies can present with cerebellar disorders. So when I'm presented with a patient with cerebellar disorders, how do I investigate the same? Well, there is a time course to be considered. There is acute, subacute, and chronic. If there's any family history, maybe genetic, maybe acquired, what other comorbidities, any toxin exposures, and of course, we'll be talking about imaging abnormalities that will give you clues, because at the end of the day, we're investigating for treatable causes. And then we'll undertake focused genetic testing if we can identify an autosomal recessive. So this particular flow chart, it's a bit busy, tells you how to distinguish cerebellar disorders. When I suspect cerebellar ataxia, I take a history examination and I rule out in the first instance the non-cerebellar causes. If it's a cerebellar disorder, I'm going to go down the brain MRI route. There'll be several other signatures I'll be showing you of cerebellar pathology. And if I may find some other extracerebellar pathologies of these types, siderosis, CJD, Wernicke's encephalopathy, I'm going off on a different target. If the blood results show me some deficiencies or immune dysregulation syndromes, I'm going down this pathway. And then I'm going down the dominant, autosomal recessive, or X-linked, mitochondrial. And then I'm in the genetic area. And if there's nothing found and there are other features of sleep disorders or autonomic nervous system disorders, I'm either landing up with multiple system atrophy or idiopathic late onset cerebellar ataxias. Right. So there is a cerebellar ataxia where the integrator is at fault, or there will be afferent ataxias from a whole host of afferent pathologies from the various different systems, which bring in fibers to the cerebellum from the vestibular eye, the receptors in the skin, and all such structures. Right. Paraneoplastic cerebellar degeneration is important because there's an underlying cancer. You are well aware of the various different markers of paraneoplastic cerebellar degeneration with their corresponding malignancies that we are aware of and we identify. There may be some other features than ataxia which helps us to sort of identify certain types of cerebellar degeneration. And it mainly is the Purkinje cells, but other cells in the cerebellum can also be affected in the various different paraneoplastic ataxias, where the cerebellum undergoes a very rapid atrophy. That's the most characteristic. And there is a subacute cerebellar syndrome with a large number of progressively increasing number of antibodies that help you identify where the primary might lie. Moving on to the immune ataxias, we have the anti-GAD ataxias, the GAD ataxias, where individuals have other autoimmune disorders. The titers don't always correlate. Thyroid can present with ataxias, and we have the high titers of antithyroid antibodies, and they respond to corticosteroids. We must not forget celiac disease, which causes ataxia as well, and it's easily treatable. So the immune ataxias, the thyroid, the gluten, multiple sclerosis is again an autoimmune disorder or an immune-driven ataxia, as is various Sjogren's disease and SLE, where, as you know, the main brunt is on the ganglions. Ganglionopathy gives rise to ataxia, in addition to sensory neuropathy. I have just laid out the posterior inferior cerebellar artery syndrome, the anterior inferior cerebellar artery syndrome, and the superior cerebellar artery syndrome. You are all familiar with the clinical picture because that's the most common cause for cerebellar ataxias presenting acutely. Toxins, alcohol, acutely does cause a pancerebellar syndrome, which is reversible, but at times, even after discontinuation of alcohol, the individual continues to have progressive cerebellar syndrome. Hypoxia, carbon monoxide, hanging, strangulation, other metabolic toxins can give rise to cerebellar pathology, as can drugs like phenytoin that we use for epilepsy, or lithium, and chemotherapeutic agents, and glue sniffing, toluene, and heavy metals can produce all this. I bring up a picture here of an MRI showing significant cerebellar atrophy from alcohol, and you can see how the anterior vermis, way in the middle, is most affected, where the gait ataxia is more prominent than limb ataxia. There are other drugs as well. We talked about the drug abuse, cocaine, heroin, methadone, and other herbs, and glue sniffing solvent. Here you find the metronidazole causing dentate signals, and other azoles can cause the same as well. Now we move on to the genetic ataxias. I'll be limited here. We can classify them into autosomal dominant, recessive, X-linked, and mitochondrial. We can also classify them as congenital. I talked about the ciliopathies and episodic ataxias 1 to 8, which is genetic. Now, spinocerebellar ataxias, these are the autosomal dominant ataxias. We have the SCA 1, 2, 3, 6, and then 17 and 7. And then there's a large group of unknown dominants that we have as the ataxias, SCAs. Here we have the constellation of a gait disorder and appendicular ataxia with dysmetria, a dysarthria, and nystagmus. In addition, there is slow saccades. They can be extrapyramidal or pyramidal, a peripheral neuropathy, or even a motor neuronopathy presentation. Now, I have laid out here some of the commoner SCAs 1, 2, 3, 6, and 7, which is 50% of the dominant ataxias. SCA 3 is the most common worldwide, and it has some clinical features which help you raise the possibility. And I've identified out here the protein that are dysfunctional and the CAG repeat that are contributing to this group of ataxias, and a possible location of the problem that gives rise to the SCA in each of these individual cases. It is at times possible to obtain some clues from eye movement examination. If you get slow saccades, you're thinking of these types of ataxias, SCA 1, 2, and you can read that. There is 48 types of SCAs that we have identified so far. So slow saccades, hypometric saccades, hypermetric saccades, gaze-evoked nystagmus, downbeat nystagmus, and so on and so forth, help you get an idea of which genes to look for. I'll be coming to that. I bring up a morbid pathology out here to show you the control cerebellar size out here compared to SCA6, how small and shrunken the cerebellum is in this particular SCA6, which is predominantly a cerebellar disorder. So autosomal recessive ataxias again can be classified into ataxias with pure sensory neuronopathy, with axonal polyneuropathy, and without neuropathy. We can also classify them into cerebellar plus syndromes, and you can see what the additional non-cerebellar but neurological features can be like. So the most common among the ataxias, autosomal recessive, is Friedreichs ataxia. I'm sure all of you have seen patients. It's mainly in the Caucasian population that we've seen them. And there are, in addition, other ataxia with oculomotor apraxia 1 and 2, and others which we can see as autosomal recessive ataxias. With next generation sequencing, we're able to identify more and more of these ataxias of the autosomal recessive types. I bring up this list to highlight Wilson's disease, which is something you can never miss because it's treatable, and you are all aware of the biomarkers, the pathology, the gene tests, and the therapy for it, and the other conditions like Refsum's disease, like cerebrotendinous xanthomatosis, Tay-Sachs, and Sandoff. I'll bring up a list at the very end. The gene tests are there, the possible enzyme deficiencies are there, And these appear to be some metabolic derangements that are caused in these situations. So Friedreichs ataxia, I just wish to highlight it because it's a common exam case. When does it start? Depends upon how much the frataxin deficiency is. So the frataxin deficiency in intronic GAA, mitochondrial protein involved in iron homeostasis, giving rise to respiratory chain abnormalities. And the features are one of ataxia, neuropathy, pyramidal signs. They also get cardiomyopathy and diabetes. And these two pictures, next two patients, this is a young person with ataxia developing very early on and very early wheelchair bound with a lot of the systemic features of Friedreich's ataxia. Contrast this to the other lady, this one, who has a more limited version of the Friedreich's ataxia developing late with not much in way of other system involvements, depending upon the amount of residual frataxin because of 30% of the enzyme still being active. The pathology of Friedreich's ataxia showing the amount of cerebellar syndrome, cerebellar atrophy, spinal cord atrophy, the significant atrophy of the posterior columns that you can see out here, and the dentate nucleus very much markedly atrophic. Ataxia telangiectasia, another disorder which we see in children, where there is the DNA repair mechanism that is disturbed, presenting with truncal ataxia, apraxia, choreoathetosis, myoclonus neuropathy. Most important is the telangiectasia. These is on the skin. You mustn't miss them because this is a common short case, including in the conjunctiva. You can see the telangiectasis, and they will have other immune deficiencies causing recurrent lung infections and malignancy predisposition, and the survival is not good. Here you see the telangiectasia I was talking to you about earlier on, and the MRI showing cerebellar atrophy. I bring up the picture of the KF ring just so that everybody sees one in this session and never misses one. Always look at the, in a person, with any neurological disorder, certainly one with a movement disorder, you must look for the KF ring. You cannot miss it because it's treatable. I bring this slide up just to bring up the pediatric version of the ataxias, where I identify several enzyme defects giving rise to ornithine transcarbamylase deficiency, citrullinemia, all of which give ataxias in the pediatric age group, where we test the blood and the urine for organic acids and amino acids. And there's a large number of disorders that are identifiable. There are a large number of progressive ataxias that you must remember. Again, all common exam questions may not have a case. Treatable ones with vitamin E deficiency, Wilson's we talked about, refsums, the treatable causes are given out here. And the pediatric causes are given out here. Please have a consideration of them. Now, moving on to the degenerative ataxias, we have multiple system atrophy, which is a degenerative, non-hereditary, presenting with a constellation of Parkinsonism, cerebral ataxia, corticospinal tract signs, but autonomic nervous system dysfunction as well. And everybody is familiar with the hot cross bun sign or the plus sign because of the pontine fibers that's shown out here. So what are we going to test for? Bloods for paraneoplastic, thyroid, thyroglobulins, celiac, B1, B12, and vitamin E, and then phytanic acid, alpha-fetoprotein for the DNA repair mechanisms. And then we're going to do gene tests based upon what we find in the family history, brain MRI, EMG, and lumbar puncture. So this is a busy slide. I would advise you can take a picture of it. And here we have a different tiers of tests that we do. We've talked about brain imaging, EEG, autonomic testing, routine bloods, antigliadin, thyroid antibodies, paraneoplastic, copper, TSH, B12. And then we move on to the next set where we are doing alpha-fetoprotein, serum ammonia, serum ceruloplasmin, CK, ketones, lactate, and pyruvate, moving on to HTLV, Lyme, and HIV for infections, and finally moving on to muscle biopsies, MRS, skin biopsy, and then the pediatric age groups, and the cholesterol, and the phytanic acid, and the leukodystrophy group. So that will catch nearly everything that you wish to identify. This slide identifies for you the MRI features of cerebellar dysfunction. So when there is a hot cross bun sign, I've shown you one. When there's a dentate nucleus calcification, it may be one of the spinocerebellar ataxia specific types. So there are MRI features of various different cerebellar disorders that will help you identify the pathology, including CJD out here, you can see. So when we come to the genetic testing, important because next generation sequencing, whole genome sequencing, whole exome sequencing are important, but the cost goes up and you must judiciously ask for the right test to identify which spinocerebellar ataxia we are likely to find out here. So that's the general flow chart for the genetics. We've talked about specific treatments of ataxias depending on whether it's celiac, vitamin E, or thyroid, or anti-GAD related, or paraneoplastic, or cerebrotendinous xanthomatosis, and some experimental therapies for Friedreichs ataxia. There is, of course, a very large role for neurological rehabilitation for ataxias. We treat them symptomatically if they have got spasticity, if they have more extrapyramidal symptoms, if it's an episodic ataxia. I didn't have time to cover it, episodic ataxia type 1 and type 2, acetazolamide. Then there's treatment with beta blockers, and we have to have NG placements. Something on gene therapy. For the spinocerebellar ataxias, we have the small RNA knockout antisense oligonucleotides. These are going to come up in the next 5 or 10 years, hopefully, and various different targets of gene expression we have. So I wish to end with some take-home messages for MD level. We must identify the ataxia phenotype, a very good clinical evaluation from history, including family history, toxin exposure, progress, and then with investigations gradually building up from tier 1 to tier 3, as I've showed before, identifying the treatable ones, which we have, and then if there's any toxins at cause, we must treat it. And then we're going on to the degenerative ataxias, no genes found, and then treat the patient's neurorehabilitation plus specific treatment wherever possible. I wish to finish with a summary of the ataxias that you are likely to encounter in your clinical practice. First of all, we have the congenital disorders. I've spoken at the beginning about the Arnold-Chiari, the hydrocephalus, the congenital cerebellar hypoplasia, the ciliopathies, and the rest in the pediatric age group. Then there's a big list in a small chart of the dominant ataxias that we have: leukodystrophies, DRPLA, episodic ataxias, and the SCAs, that is 1 to 48 so far and counting. The ones which have an autosomal recessive inheritance, where we have the aminoacidureas, the ataxia with oculomotor apraxias, the ataxia telangiectasia. Then we have the CTX, treatable, Friedreichs ataxia, which is a very common case, the various different pediatric ataxias, the leukodystrophies with hallmarks on the MRI, the lysosomal storage disorders out here, and then we have the PCANs in the movement disorder, the Refsums, and Unwied-Lundborg, and the most important treatable one is Wilson's. Moving on, we have the ones with X-linked inheritance, the adrenomyeloneuropathy, the Fragile X, Tremor-Ataxia syndromes, ornithine transcarbamylase deficiency, pyruvate dehydrogenase, X-linked leukodystrophy, and sideroblastic anemia. There's a huge number of mitochondrial disorders, maybe maternal, maybe paternal as well. And you're familiar with the Kearns-Sayre, the Sandow syndrome, the other ones that you can see out here. The muscle biopsy will be giving you clues, but there can be a differential placement of the cerebellar, of the mitochondrial involvement. The toxic and metabolic disorders, alcohol, very important, hypoxia from carbon monoxide, large number of drugs, extrapontine myelolysis. Then we have the various different magnesemia, hypoparathyroidism, hypothyroidism, insecticides, and toxins that we have out here. Moving on to the infectious group, there's a big list of various different pathologies, from viruses, from bacteria, from plasmodia, and you have the whole list laid out here. The strokes presenting acutely will give you ataxia. The vitamin deficiencies, B12, E, B1, zinc, cancers, either structural pressure on the cerebellum or paraneoplastic, and you have the whole list out here. Autoimmune, we've talked about the ADEMs, the Bickerstaff, the celiac, the GAD, and the Miller-Fisher MS, sarcoid. And then we have the vasculitis, temporal arteritis. We talked about SLE and Sjogren's. Then we are coming on to the sporadic ones, multiple system atrophy, neuroacanthocytosis, PCANS, and PSP. And then we will have other ataxias from pathology in the afferent circuits giving rise to ataxias, neuropathy, migraines, obstructive hydrocephalus, and of course, psychiatric causes at the very end. Well, thank you very much for about half an hour of studies on ataxia, treatable ataxias. I invite you to explore the ataxia subject further through the standard textbooks, Harrison's being one, neurology books, including Adams and Bradley being one. And thanks for listening, and best wishes till we see each other again for another topic on neurology. Long live IMA. Thank you very much. And if you have any questions later on, you're welcome to send me an email and I'll try to answer them. Thank you and good luck. Bye-bye.